urinary incontinence and pelvic organ prolapse in women. So welcome all to the today's session. The session is on urinary incontinence and pelvic organ prolapse in women management. This is a NICE guideline published on 2nd April 2019. We begin with our code Master MRCOG with concept oriented clarity. So what does this guideline cover? This guideline covers MDT organization, surgical data registry, assessment of urinary incontinence. Okay. So how this MDT or a multidisciplinary team is organized, and it talks about the registry and assessment of urinary incontinence. So organization of specialist services. There are two types of MDT. One is a local MDT and another there can be regional MDT. Please understand these concepts well. Okay, because the composition of the local MDT is different and the composition of the regional MDT is different. Sometimes they can ask you following out of this who is not a part of local MDT or who is a part of regional MDT, etc., etc. Okay, or who is not a part of this. So we need to know what is the composition of the local MDT and what is the composition of the regional MDT. So what exactly this local MDT does? It reviews all proposed invasive procedures for primary stress urinary incontinence or active bladder or primary pelvic organ collapse. So basically, these MDT will look into the either incontinence or pelvic organ prolapse, and they will review all invasive procedures which are planned for either SUI or OAB or active bladder or pelvic organ prolapse. They will also review the management if input from wider team is needed. Okay. They will work within an established clinical network with access to the regional MDT. So they will also have an access to the regional MDT. If there is any issue, they may take the opinion of the regional MDT also. So what is the composition of the local MDT? So it must include two consultants. Okay. So what is must and what may be an additional that you should know. So the local MDT should have two consultants. That is the one with urinary incontinence and or POP specialist, that is pelvic organ specialist. It is and or. So these two consultants may be specialists in managing the cases of urinary incontinence or managing the pelvic organ prolapse. Then there should be specialist nurse, that is urogynecology, urology, or continence nurse. There is always a specialist nurse for oncology, for everything there is a specialist nurse. So you need to have one specialist nurse of urogynecology, urology, or continence, and pelvic floor physiotherapist. So these are the must component for the local MDT. Okay. So local MDT will have two consultants. The consultant with special interest in urinary incontinence or pelvic organ prolapse and or. Okay. Then specialist nurse and pelvic floor physiotherapist. It may have an additional elderly care team member, occupational therapist, and colorectal surgeon. Remember here, colorectal surgeon is a optional. Okay, and we will see the composition of the regional committee in the next slide. So all local MDT members should attend the meetings. Okay. Now regional MDT. When to refer to the regional MDT? So refer if repeat continence surgery is planned. Okay. So if the patient has already undergone continence surgery and if the repeat surgery is planned, then we need to have this regional MDT referral. Okay. So they may give you the scenario and may ask you the next step. So here it will be regional MDT referral. Okay. If there is a repeat same site prolapse surgery, okay, either incontinence surgery is repeated or the same site prolapse surgery is repeated, preferred treatment is not available locally. Okay, then also you go for regional MDT opinion. Okay, then coexisting bowel problems needing colorectal input, vaginal mesh for prolapse is a consideration. Then mesh complications or unexplained symptoms after the mesh surgery. So any mesh related complication, you need to take into account the regional MDT. Okay. Woman wishes surgery but may want future fertility preserved. So again, the case needs to be discussed in the regional MDT. Okay. Now, what are the components or what are the people who are included into the regional MDT? Okay. So it should have a urogynecology subspecialist. Okay. One urologist. Okay. There will also two consultants, but they mention in consultant with urinary incontinence and or POP special interest. Here you need to have urogynecology subspecialist. That means the person may be gynecologist with the subspecialty in the urogynecology, then urologist. Okay, two consultant, but here there is a urologist. Okay, then specialist nurse, it was there in the local MDT also, pelvic floor physiotherapist. So these, there were two consultants there, and specialist nurse and physio pelvic floor. These are common things. But here there is a little difference. There has to be one urologist and one urogynecology subspecialist. Okay. Then pelvic floor radiologist. So imaging is very, very important in regional MDT discussion. Then colorectal surgeon, it was optional there, and pelvic pain specialist. But here it is must. Okay. So you have the imaging, that is why radiologist is compulsory. Then we are going to deal with mesh related complications and all, colorectal surgeon and pelvic specialist. So did you understand the composition of the regional and the local MDT now here? Must
Yes,
component.
sir.
Okay. Now it may
Yes, sir.
have an additional biofeedback or specialist, then clinical psychologist, elderly care team here. That was also optional here. Occupational therapist optional here. There are in both cases. Obturator region surgeon, plastic surgeon. These are optional. Okay. Then regional MDT access, these regional MDT should have additional access to the psychology, psychosexual counseling, chronic pain services, bowel symptoms management, and neurology. Because there are multiple factors which are associated with these kind of symptoms. The patient, quality of life is getting affected, especially when these patients are who are coming to the MDT. So they need to have access to the psychology, psychosexual counseling, especially when you are answering in part 3, you need to involve these people. That is why they assess the
Sir, you're not
communication.
audible, sir. Oh,
Okay. Now, is it audible or no?
yes, sir. It is audible now, sir.
It is audible. Okay. So, especially in part 3, there is a specific domain which they need they assess is a communication with the colleague. And here you need to involve the multiple people. That is psychology, psychosexual counseling, chronic pain services, bowel symptom management, neurology, etc. Okay. So data collection on surgery and complications. So there is a specific registry for the data collection on surgery and complications which are related to the urinary incontinence surgeries and the pelvic organ prolapse. So we need to obtain consent for entering data into the national registry for SUI surgery, pelvic organ prolapse surgery, complication management, and women must receive the copy of their data. Okay. Now, what is the mandatory data for registry? So which data we need to enter into the register? So like a patient's details, NHS number, provider details like hospital, who is the health provider, hospital, consultant's name, procedure, what was the procedure which was performed, date and details of the procedure. Mesh procedure, if it is a mesh procedure, then material, manufacturer, unique code and sutures, that also you need to mention. Then Calpo suspension, what are the types of sutures which were taken? If the bulking agents are used, then what is the material which is used, manufacturer and unique code that needs to be mentioned. Complications, the date and investigations pertaining to the complication that we need to mention. And management, then on which date and what is the surgical or non-surgical intervention that has been carried out, that needs to be mentioned into the registry. Okay. And follow-up data over a period of 5 years must include validated outcome measures. So what is the outcome of the, because you are uh, uh, entering the surgeries also. So at the end of 5 years, validated outcome measure should be there. Adverse events, adverse events, if there is a including the pain, that should be noted, and suspected or confirmed mesh complications. Okay, there should be annual reporting. Registry should report annually and be quality assured. So there should be some quality assurance measures also. Coming to the assessment of urinary incontinence. When you are assessing the urinary incontinence, history and examination is going to be very, very important. First, what we need to do, first is the most important thing, you have to categorize the urinary incontinence clinically. Whether it is a stress urinary incontinence, or whether it is a mixed urinary incontinence, or whether it is a urge urinary incontinence or overactive bladder. Okay. Sometimes there can be stress, or sometimes there can be urge, or sometimes there can be mixed also. So what is clinically, depending upon the symptoms of the patient, the proper history, that we need to work it out. If it is a mix, okay, then target treatment will be as per the predominant symptoms, whether it is a urge which is predominant or whether it is a stress that is predominant. Okay, if it is mixed, then you will target your treatment towards the predominant symptom. Okay, if the SUI is predominant, discuss non-surgical options before offering surgery. Okay, and identify predisposing or precipitating factors and exclude the alternative diagnosis. And the conservative measures such as pelvic floor muscle assessment you will do. Perform digital examination before supervised pelvic floor muscle physiotherapy. Okay, pelvic floor muscle treatment. So you have to do the pelvic floor muscle. You need to give the physiotherapy, and you will do the digital examination before you advise the exercises. Okay, PFMT. Then urine testing. Urine dipstick interpretation test is done on the routine on the urine for blood, glucose, protein, leukocytes, and nitrites in the urine. Now here they will ask you the question on this slide. Please concentrate. If the patient has got urinary symptoms and your test, that is the urine test, is positive on leukocytes and nitrites, both are positive, then what will you do? Patient is symptomatic, the test is positive, you will start the antibiotics, but you will send the MSU. So you send the midstream urine culture and you start the antibiotics. Okay, because the patient is symptomatic, the test is also positive for both. Okay, so when they will give you the scenario, look into it whether the patient is symptomatic or and whether the test is positive for both. Okay. Now another scenario, the patient is symptomatic, but it is positive only either for leukocyte or nitrite, but not for the both. Here you will send the midstream urine culture and you will consider the antibiotics. You will not start the antibiotics, but you may consider the antibiotics. So if there will be options, so which option you are going to select? Consider the antibiotics if either of these is positive. Okay, if there are no symptoms, the patient is asymptomatic but the test is positive, okay, for both, then you will send the midstream urine culture, but you will not start the antibiotic because patient is asymptomatic. You will wait for the report and then you will start the antibiotics. Okay, then if the patient does not have symptoms and the test is also negative, you don't have to even send the MSU also. There is obviously there is no need for the treatment. Okay, so generally they ask you the question, SB type of question here. Okay, so you have to see whether both are positive or not, whether the patient is symptomatic or not, and with what will be the requirement, MSU and antibiotics. Appropriate option you need to select. Okay, here you will start antibiotics. Here you will consider antibiotics. Here you will not start the antibiotics. You will only send the MSU. Is this clear to you, doctor?
Yes, sir.
Okay, yeah. There should not be any confusion, and you should not lose marks for such a simple question. Okay. Then post-void residual, you need to measure. Okay, measure PVR if there is a voiding dysfunction symptoms or there is a recurrent UTI. And how will you measure the post-void residual? You'll prefer the bladder scan over the catheterization. We also need to check for the bother score or the symptom score. Okay, use validated urinary incontinence specific score when evaluating the therapy. And you will always ask the patient to maintain the bladder diary. Use in initial assessment minimum 3 days, covering the work plus leisure variations, and pad testing is routinely not recommended. Bladder diary we have already seen in the last session. Okay. Fine. So urodynamic testing. When not to perform urodynamic testing before primary SUI surgery, if SUI or SUI predominant mixed urinary incontinence, which is confirmed by detailed history or demonstrated SUI on examination. Okay, this we have already seen in the last discussion, that if you have a pure SUI on clinical examination, then urodynamic testing is not required. Okay, the role will be only in view of medical legal purpose, but otherwise it is not required for clinical management point of view. Now, when to perform? Prior to the SUI surgery, if there is urge predominant, mixed urinary incontinence or unclear type. But if it is a stress predominant, then it is not required. But if it is a mixed but urge predominant, it is required. If there is a suspected voiding dysfunction, if there is an anterior or apical prolapse, if there is a previous SUI surgery. And other tests which are not recommended in evaluation are Q-tip, Bonnie's test, or Marshall test, or fluid bridge test, these are not recommended. Cystoscopy is not recommended in the initial urinary incontinence assessment, and imaging, MRI, CT, X-ray, ultrasonography, except for post-viral residual. Okay, so these tests are not recommended. So, doctor, can you enumerate the indications for urodynamic testing? Four indications. Four indications.
Yes, sir. It is done prior to surgeries if there is a urge predominant mixed urinary incontinence or which is unclear,
Mhm.
suspected avoiding dysfunction, or there is an anterior or apical prolapse, or there is a previous SUS surgeries.
Yes, these are the four indications you remember, because if the scenario is involving either of these condition, the test which is of choice will be the urodynamic test. Okay. Now, indications for specialist referral. If there is a persistent bladder or urethral pain, palpable bladder after voiding, benign pelvic mass, fecal incontinence, suspected neurological cause, voiding difficulty, suspected urogenital fistula, previous incontinence, pelvic cancer surgery, previous pelvic radiotherapy, follow suspected cancer referral rules for hematuria and recurrent unexplained UTI. So remember, if these symptoms which are involving maybe the bladder or you are suspecting some urogenital fistula, these require a specialist referral. So if your scenario is involving this complication, it will be your next step will be specialist referral. Okay. Then coming to the non-surgical management of urinary incontinence. Okay, the first is a lifestyle intervention. Okay, you will always ask the patient to reduce the caffeine for overactive bladder, modify fluid intake if it is very high or very low, and ask the patient to reduce the weight. And if the patient's BMI is more than 30, you will ask the patient to lose the weight. Okay, and the appropriate referral we need to do. Then physical therapies such as pelvic floor muscle training, PFMT is required. It is first line for stress urinary incontinence and mixed urinary incontinence. What is the duration for SUI? It is for 3 months. Okay, pelvic floor muscle training is required for more than 3 months. 8 contractions 3 times a day for 3 months. Okay, and this duration you need to remember. Most of the students get confused, especially they appear in part 3, because for prolapse it is 16 weeks it is required, but for urinary incontinence it is 3 months of PFMT which is required. Okay, so 8 contractions 3 times a day for 3 months. Okay, for SUI and mixed urinary incontinence. Okay, continue long term if it is beneficial. Do not use perinometry or EMG feedback routinely. Okay, electromyography biofeedback is routinely not required. Electrical stimulation not routine for overactive bladder or combined with PFMT. It may be used if woman cannot contract pelvic floor muscles. Okay, then only you go for electrical stimulation, but it's not a routine. Okay, it may be used if the woman cannot contract the pelvic floor muscle. Then next conservative measure is a bladder training. So this bladder training is required especially for urinary incontinence, urge predominant urinary incontinence, or if there is a overactive bladder or mixed urinary incontinence which is urge predominant. Okay, and the duration is 6 weeks. Remember, this bladder training is for 6 weeks. Okay, here voluntarily the patient will postpone the urine. When there is a desire to pass the urine, patient will postpone the passing the urine initially for shorter, maybe for 5 minutes, and this duration over a period of time they will increase. That is how one needs to train the bladder. Okay, and this is what is the treatment for overactive bladder. Conservative treatment in overactive bladder will be bladder training for 6 weeks. If it is a stress urinary incontinence, then it is a pelvic floor muscle training for 3 months, 8 contractions 3 times a day. Did you get the difference between the two? If there is a SUI and if there is overactive bladder, what kind of treatment you are going to advise?
Yes, sir.
Okay. So if benefit is insufficient, combine overactive bladder medicine and bladder training. So when you are dealing with overactive bladder, in that particular case, the first will be the bladder training. Okay, if for 6 weeks, if there is no benefit, then you will add medicine, that is anti-muscarinic medicine, and also the continue with the bladder training. Okay. Now neurostimulation. Okay, that is you have TENS, then transcutaneous posterior tibial nerve stimulation. Both these are not recommended. The TENS is also not recommended. That is transcutaneous sacral nerve stimulation is not to be offered. Transcutaneous posterior tibial nerve stimulation is also not to be offered. Then what is permitted is a percutaneous PTNS, that is posterior tibial nerve stimulation. Transcutaneous is not advised, but percutaneous posterior tibial nerve stimulation only after MDT review. And if the non-surgical plus or active bladder medicine, that is anti-muscarinic medicines, are ineffective and woman declines botulinum toxin A or sacral nerve stimulation, then you go for PTNS. Okay. So the for overactive bladder training is first. If not effective, then you add antimuscarinics, that is medicines. If that is also not effective, then go for botulinum toxin or sacral nerve stimulation. But if the woman declines these two options, then go for percutaneous posterior tibial nerve stimulation and not the transcutaneous. So is it clear the management of the overactive bladder? First,
Yes, sir.
bladder
Yes, sir.
training, then go for antimuscarinic agent. Then next step will be botulinum toxin or sacral nerve stimulation. If it is declined, then go for PTNS. Okay. So this flowchart you should remember. Okay. Then containment products and toileting aids, not a treatment, but they are offered only for interim coping, adjunct to the therapy, and after all treatment options are explored. So these are temporary measures which you can advise, such as pads and all. So they are not a treatment, but they are interim coping adjunct to the therapy after all treatment options are explored. You need to assess the patient annually, assessing continence, skin integrity. If you are putting your patients on these pads, no, toileting aids, no, then you have to see them annually and check for continence, check for skin integrity, symptom, medical and social changes, and product effectiveness, and review by trained registered professional or supervised non-surgical, non-registered worker. Okay. Not from part 2 point of view, but part 3 point of view, you need to talk about these measures is in the urogynecology station. Okay. Now, what is the role of catheterization? Consider catheterization for persistent retention causing incontinence, recurrent symptomatic urinary tract infection, then renal dysfunction. Then in that particular case, we might consider the catheterization. Indwelling catheters may not improve urgency or urge urinary incontinence. Intermittent catheterization is preferred if the woman or carer can perform it. Long-term indwelling catheters, discuss risk and lifestyle impact. Indications will be chronic retention, skin wounds contaminated by urine, severe distress from leakage, or patient preference. So these long-term indwell catheters are generally not preferred. They will come into picture only in certain or in later stages. Okay. The suprapubic catheter may reduce urinary tract infection. Bypassing and urethral complications can be reduced by suprapubic catheter. Okay. Then devices, do not use intravaginal or intraurethral devices routinely. It may be used occasionally during exercise, etc. Okay. There are certain devices which are used intravaginal. Okay. Now, coming to the medicines for overactive bladder. Before starting overactive bladder medicines, counsel the woman on likelihood of the success. Now, concentrate on this particular slide well, because especially for part 3, definitely there is a station on the medicines for overactive bladder, and you need to talk about the side effects and what will be the review and all. Okay. So when you are thinking about the medicines for overactive bladder, mention the likelihood of success, common side effects such as dry mouth, constipation showing the drug effect, then may require more than 4 weeks for the benefit. So once you start, it is not immediately they will be act. Generally, benefit is after 4 weeks. Okay. Uncertain long-term cognitive effects of anticholinergics. Okay. So there may be long-term cognitive effects of these agents also. So coming to the choice of the medicine, what is not to be offered? Fluoxetine, Propanthine and imipramine, these are not effective, so these are not preferred. Oxybutynin immediate release in elderly patient is not to be used. It has got a high risk of deterioration, especially for the cognitive function. Okay, so avoid oxybutynin in elderly patients. Okay, so when you are looking that your diagnosis is overactive bladder, look at the age of the patient which is given in the scenario. And if it is an elderly patient, then do not select the oxybutynin. Okay, then what is the strategy which we need to follow? We will offer lowest cost anticholinergic first. If it is ineffective or not tolerated, we will switch to another low cost option. Transdermal therapy, if oral drugs are not tolerated, there is an effect, but uh, the patient is not tolerating the side effect. That means then go for transdermal therapy. Okay. Mirror background, as per the NICE guideline, you can go. And then desmopressin for troublesome nocturia, age more than 65 plus CVD or cardiovascular hypertension, then you will avoid this. Okay. So desmopressin, if there is a troublesome nocturia, in that particular case, desmopressin is the drug of choice, but to be avoided in age patients more than 65. Other medicines, do not use systemic HRT for urinary incontinence. Okay. Intravaginal estrogen, you can use for overactive bladder symptoms in postmenopausal women with atrophy. Okay. But the systemic HRT for urinary incontinence is not advisable. Intravaginal estrogen, yes. But especially patients who have got a postmenopausal women with atrophy, in these cases, you can think of intravaginal estrogen also. Okay. Then duloxetine, that is not a first line drug for stress urinary incontinence. The treatment for stress urinary incontinence is PFMT, surgery, and if decline, then comes the role of duloxetine. Okay. So it is not a first line treatment for stress urinary incontinence. So when you are given a scenario, look for what exactly, whether the patient is declining the treatment which is offered, wants the conservative management, then duloxetine will be preferred. Okay. It is a second line only if women prefers medicine over the surgery. Okay. Now, reviewing the medicine, if you have started the patient on, say, antimuscarinic, you will review at 4 weeks. It will be face-to-face or telephonic interview. Then if optimal improvement is there, we will continue with the same. If there is inadequate, then adjust the dose or switch the drug and again review the patient at 4 weeks. So always review is at 4 weeks when you start them on medication. Okay. Review earlier if there are intolerable side effects. Refer to secondary care if multiple medicines fail. And long-term users, once they are stable, then you can review them 12 months or 6 months if the patient is 75 years. Okay. So initial review will be 4 weekly till the symptoms become stable. And then it will be 12 monthly. Or if the patient's age is more than 75, then 6 months. Okay. Now, what are the invasive options for overactive bladder treatment? Overactive bladder. Okay. For overactive bladder, generally invasive options are not preferred. Medical line of management first. We will always do the urodynamics prior to the invasive treatment, and the invasive options for the overactive bladder, we have already seen few. That is botulinum toxin A, then percutaneous sacral nerve stimulation, augmentation cystoplasty, and urinary diversion. So that is what is the flow chart for overactive bladder. Okay. So bladder training, then medicines, then botulinum toxin, then percutaneous sacral nerve stimulation. If both these decline, then you may think of what we can think of posterior tibial nerve stimulation. Okay. Then augmentation cystoplasty and urinary diversion. Okay. Now, the dose of botulinum toxin. Okay. Actually, there is little difference in the talk article and in the NICE guideline, but what the NICE guideline has given, that we will follow. Okay. In the botulinum toxin A, offer 100 units after local MDT review if detrusal or activity is confirmed. Okay. Then may consider even if detrusal or activity not demonstrated after MDT. Okay. So generally after the local MDT, you go for botulinum toxin and the dose is 100 units. Okay. You will counsel the patient on risk of needing intermittent catheterization. Okay. This intermittent catheterization is clean intermittent catheterization is required if you put the patient on botulinum toxin, and you need to train your patient for CIC, that is clean intermittent catheterization. There is a possibility of UTI risk and uncertain long-term duration or risk. Okay. Treat only if patient is willing to perform CIC if needed. So this botulinum toxin A, the dose is 100 units, and the patient need to be trained in CIC. The patient should be willing to perform CIC. If there is inadequate benefit, you can increase the dose to 200 units. Okay. And the review is at 12 weeks. Okay. For medicines, it was at 4 weeks. If you go for botulinum toxin, the review is at 12 weeks. And do not use botulinum toxin B. Okay. So this question may be asked about the dose, and this they may combine botulinum toxin A 100 units, botulinum toxin B 100, botulinum toxin A 200. So the initial dose as per the NICE guideline is botulinum toxin A 100 units. Okay. Then percutaneous sacral nerve stimulation offer after MDT if medicines have failed and botulinum toxin is ineffective or woman declines botulinum toxin A. Discuss long-term implications such as test phase plus failure rate, need for revisions, and long-term commitment. Okay. Allow self-referral if symptoms recur. Next is augmentation cystoplasty for idiopathic detrusor overactivity, which is not responding to all conservative and medical therapy. Only if women can self-catheterize. Counsel on risk of bowel issues, metabolic acidosis, mucus retention, urinary tract infection, retention, malignancy risk, and lifelong follow-up is required. Okay. So augmentation cystoplasty is a complicated surgery. Next, last resort is a urinary diversion. Okay. Non-surgical management, if it is failed, then botulism toxin, sacral nerve stimulation, cystoplasty is unsuitable or unacceptable, and this also requires long-term follow-up. Okay, so that is the last treatment for the urinary diversion. Okay, so that finishes the topic of urinary incontinence NICE guideline. Thank you.